Okay, so there's a big debate happening. Is uh, cholesterol is in our blood, and it can come through diet. It may not come through diet. We are generating cholesterol ourselves, and then there's LDL-C, then there's HDL, then there are different particles and particle sizes. What is the biggest risk that you feel is the most necessary element that we need to monitor?
So I think it's mostly just educating people what is actually going on. Cholesterol is not bad for you. You're not going to be alive if you don't have cholesterol. It's the lipoproteins that are carrying the cholesterol through your blood vessels, which potentially could be a problem. And it's the apolipoprotein B or ApoB containing particles. So those are the LDL particles, the VLDL particles, the ILDL particles, and LPLA, which up to 20% of the population has LPLA. So it's the ApoB particles that people need to be monitoring.
In the past, you would call, yeah, as you mentioned, that these are just particles. However, in the past, LDL would be bad cholesterol, HDL would be the good cholesterol. Currently, more ApoB is considered a better marker, and you also mentioned LP little a. Uh, then there's people considering that, okay, you have to look at homocysteine levels, CRP levels, inflammatory markers, interleukin 6 perhaps. How does this all tie in? This is tricky for, I wouldn't say cardiologists, but at least regular physicians. How would a regular individual or a patient go about assessing, okay, what is good and what is not that great?
So you'd mentioned many of the tests, and those are great markers. I usually break them down to three big buckets. So there's a bucket that's going to be affecting nitric oxide and nitric oxide availability. There's going to be a bucket that looks at inflammation and oxidative stress, and there's going to be a bucket that looks at the lipoproteins. And there's various vendors or lab companies that can do these tests. I just particularly tend to use a lot of Boston Heart Lab and Cleveland Heart Lab because they have a lot of the inflammatory markers that I want to look at. And, just start with a few of them. And then as you get more comfortable with them, then you branch out and start looking at them. But, you know, the failure is to think that it's, going to be simple. If it was just about cholesterol, smoking, high blood pressure, diabetes, and obesity, there wouldn't be heart disease. Unfortunately, there may be 395 other risk factors affecting your arterial lining. So that's why I'm so big about talking about the endothelium and the endothelial glycocalyx. Yes, lipoproteins are important, but it's the response to what happens to the injury of the artery. It's the oxidative stress, it's the inflammation, it's autoimmune dysregulation. That's what's really the problem. You're just trying to stop that process from kicking off these cascades in the arterial wall.
Right. So, endothelial dysfunction, a huge topic, and we are looking to learn more about it, and it can be fairly perplexing. Uh, how does endothelial dysfunction actually happen in the first place, and um, genetic factors or modifiable factors, and how it can we mitigate them? That's the initial injury that we're looking at, and how do we go about minimizing that as much as possible?
So the endothelium is the inner lining of your blood vessels. It's one cell thick and lines the entire luminal surface of the arteries. And if you could strip out your endothelium from your arteries, it'd be approximately the surface area of 6 tennis courts. So it's one of your largest organs you don't know you even have. But the endothelium also is protected by something called the endothelial glycocalyx, which is sugar husk or sugar coating in Greek. It's a protective coating. Think of it as like if you took a fish out of water and it's slimy, that's essentially the consistency of the endothelial glycocalyx. And the endothelial glycocalyx was first visualized in the 1960s with electron microscopy. And only in the past few years has it become more and more relevant that it's the endothelial glycocalyx that's actually protecting the endothelium. And so when this glycocalyx gets injured by oxidative stress, inflammation, insulin, glucose, heavy metals, infections, infinite insults, then the underlying endothelium is impaired. And when the endothelium is impaired, it stops releasing as much nitric oxide. Without nitric oxide, the arteries become stiffer. Your blood pressure starts to rise. Without nitric oxide, the lipoproteins, the white blood cells, they start sticking to the artery like Velcro, and then they can kick off this cascade that's going to lead to plaque.
Thanks for watching, and I appreciate you as a valuable viewer. And if you liked this segment, you can watch all of the different individual segments or the whole podcast to have a broader understanding on this topic. Just check the links in the description or what you see on the screen right now. I'm Dr. Umar Khan. Looking forward to seeing you again. Thank you.